Buen día. Bueno, en primer lugar, quiero agradecerles a ustedes, pero sobre todo quiero agradecer a Sir Peter Barnes, que esta mañana nos va a permitir no solamente escucharlo, sino también, que creo que es lo más importante, poder interactuar con él. Sobre todo las preguntas que ustedes quieran hacer, que supongo que van a ser muchas, él va a estar disponible para contestarlas. La idea de que Peter Barnes venga a la Argentina nació hace muchos años, en el año 1995, cuando trabajábamos en la Fundación Favaloro. Yo le planteé a Favaloro la posibilidad de tener un profesor visitante. Y Favaloro aceptó la idea y durante una semana Peter Barnes estuvo en la Fundación Favaloro, fue una semana extraordinaria, donde pudimos intercambiar con él muchísimos de sus conocimientos novedosos, sobre todo en el área de los mecanismos del asma y de la enfermedad pulmonar obstructiva crónica. A través de todos estos años hemos mantenido la relación con él y esta oportunidad de invitarlo se dio precisamente el año pasado, cuando nos encontramos durante un congreso de la viernes y gracias al apoyo del laboratorio Astra, hoy ha sido posible. Quiero comentarles que las conferencias de Peter van a estar todas subidas a la red, de modo que los diapositivos, que obviamente son muy importantes, y sobre todo lo que él habló ayer, que fue una cosa realmente muy novedosa, que es sobre lo que él ha investigado sobre el envejecimiento, tomando como modelo el envejecimiento del pulmón en la enfermedad pulmonar obstructiva crónica, con las concomitancias de todas las enfermedades que se producen frecuentemente en los pacientes que tienen enfermedad pulmonar obstructiva crónica. Bueno, sin más, le voy a pedir a Sir Peter que nos dé su conferencia. Peter.
Thank you very much, Nico, and good morning, ladies and gentlemen. I want to start by thanking AstraZeneca for sponsoring my visit, and particularly Ariel for agreeing to fund my visit, which has been extremely enjoyable, especially the ceremony last night. So today I'm going to talk about updates in asthma and COPD therapy, and because you're all specialists, I will go very quickly through the talks because I think it's important to have time for discussion. So let me start with asthma, the first meeting. So I'm going to talk about poor control of asthma in the real world and the overuse of short-acting beta agonist relievers. I'm going to talk about the new concept of anti-inflammatory relievers, and then finally discuss some of the new therapies for severe asthma. So we have extremely effective inhaled therapies for asthma. And this is a study from my colleague Martin Partridge, who looked at asthma control using a standard questionnaire in several European countries, including the UK. And all of the patients had been prescribed inhaled steroids, and the majority were on a combination of inhaled steroid and long-acting beta agonist. And yet you can see that half of the patients were uncontrolled, and only 28% were well controlled, which is the aim of treatment. This is quite shocking, given that the treatments are highly effective for the vast majority of patients. Similar findings were seen in other parts of the world. So they did similar studies in North America and Asia. In Asia, the results were even worse. And even a more recent study that was done in the UK by David Price showed that still nearly half of the patients with asthma are uncontrolled and having to be admitted to hospital with acute exacerbations. So this is quite disgraceful, given that we have effective treatments. And of course, the reason why the figures are so bad in the real world is that patients don't use their inhalers. So there's, in particular, very low adherence to regular inhaled steroids. Less than 20% of asthmatic patients take inhaled steroids regularly. And this is true even of doctors with asthma, of which I'm one. I used to have asthma, I don't now. But doctors don't adhere to inhaled steroids either, even when they know they should be taking them. So this is a big problem. The other problem is that patients are not using their inhalers correctly. So poor inhaler technique is extremely common, and that's because most family doctors have no idea how inhalers should be used, so they can't teach their patients the correct use. And these two factors account for this very poor control of asthma in the real world. So people are over-reliant on SABAs, and these are the most widely used asthma therapy in the world today. They're usually used as a reliever therapy as required to relieve symptoms. But we know that when patients are using a lot of SABA, asthma control actually gets worse. And that's because frequent beta agonists increase eosinophilic inflammation in the lungs. So although the patient feels better for the time they're bronchodilated, the inflammation underneath that is causing the bronchoconstriction and symptoms is actually worsening. And it was shown that overuse of SABAs was also linked to increased asthma mortality. So this is a study that was done in the UK looking into asthma deaths. So asthma still kills people in the UK. In fact, in children, the deaths from asthma are still increasing in the UK, which is shocking when you have a treatment that completely prevents asthma death. And we usually think that asthma deaths would be confined to people with the most severe disease, but you can see that mild and moderate asthmatics may also die of asthma. And these deaths were associated with overuse of SABA. So some patients are using enormous numbers of reliever medication. And as they get worse, because of the medication, they use even more reliever. So they get into a vicious cycle of overuse. But the greatest problem of all is the underuse of inhaled steroids. And that's because patients don't think the steroid inhaler is helping their symptoms, which it doesn't immediately, so they stop using it. And when LABAs came along, some patients switched to LABA. So not only did they stop taking their steroids, they actually took a treatment that would kill them. And we now recognize that LABAs should never, ever be given to an asthmatic patient unless they're combined with a steroid, because otherwise you have a high risk of death. So if you look at asthma death and relate it to SABA use, you can see that the more the canisters of SABA that patients are using, then the greater the risk of death from asthma. And conversely, the lower the dose of inhaled steroids patients use, the higher the risk of mortality. So we know that if patients use regular inhaled steroids, they almost never can die of asthma. So almost every death from asthma is due to a lack of inhaled steroids. So the problem is over-reliance on SABA relievers at the expense of inhaled steroid therapy. So this led to a global program of research to look at SABA use in different parts of the world and to see how the overuse of SABA was related to clinical outcomes in asthma. So this was the largest real-world analysis of SABA use in different regions of the world. So they looked at different areas of the world, so Europe, Asia, America. And what this program of research showed, because the results were similar in each area of the world, is that people using 3 or more SABA canisters a year as a reliever were associated with an increased risk of exacerbations. And this was a widespread problem, irrespective of the region of the world, the severity of asthma, or prescription of inhaled steroids. So 40% of asthma patients of all severity were overprescribed SABAs. And in those patients, there was a 30% increase in severe asthma exacerbations. So if you actually look at the problem throughout the world, you can see that it applies to every country in the world. So Argentina, you have 32%, which is sort of about average, but you can see that it is true across all the regions of the world. The worst country in the world is South Africa, with 75% using over this critical amount. And not only is the overuse of prescribed SABA, but in some countries you can actually buy SABA over the counter, which adds another 20% or so. And this is particularly dangerous. SABA should never be available over the counter because they kill people. And people, when they get worse, go and buy more and more inhalers, but this is going to kill them. So this has to be addressed in the management. So if you look at the overprescription of SABA, you see the more SABA people are using, there's like a dose response for severe exacerbations. And this is obviously a big clinical problem worldwide. And you can see that the more SABA people are taking, the less well is asthma controlled. So this is a global problem that needs to be addressed. And that led to 2 studies known as SIGMA, which looked at SIGMA Symbicort, so ICS LABA, given as needed in people with mild asthma. And this study produced very clear results because it was a very large study over 1 year, and there were 3 groups of treatment in the first SIGMA study. So these were people with mild asthma, so they could use the SABA as needed, which is what most of them were doing. They could have SABA with maintenance low-dose budesonide, which they take twice a day, or they could take the combination Symbicort as a reliever instead of the SABA alone. And you can see that with Symbicort reliever, that there was a 64% reduction in exacerbations compared with SABA as a reliever, and it was similar to when they took the low-dose inhaled steroid as a maintenance treatment. But this study carefully monitored patients, so they were quite adherent with inhaled steroids because they had a timer in their inhaler device, so they knew that they were being monitored. So they had an artificially high adherence to inhaled steroids. And you can see that this was 80%, which is very different from the real-world adherence, which, as I mentioned, is less than 20%. There was a second study called Sigma 2, and you can see both of these studies had very large numbers of patients. There are about 4,000 patients in each of these studies. And what you can see is that in the second study, which was a simpler design, that exacerbations were no different in the Symbicort reliever group compared with the regular inhaled steroid and SABA. And in this study, adherence was also quite high, so quite different from the real world. So if you look at the amount of inhaled steroids needed to control asthma, you can see that with Symbicort reliever, to achieve the same control as inhaled steroids regularly, you can achieve this with an over 80% reduction in the dose of inhaled steroid, which is obviously a good thing. And you can see exactly similar data in the Sigma 2. So this is overwhelming evidence that Symbicort reliever is as good as regular inhaled steroid with SABA, providing people take the inhaled steroid, but they don't. So Symbicort reliever is good as low-dose inhaled steroid with a 75% reduction in the dose of inhaled steroid needed. But these controlled trials are quite artificial and don't reflect real-world behavior. So this is a study that was done in New Zealand looking at a more real-life open-label study. And they also had 3 groups like Sigma 1. They had the SABA reliever, the ICS maintenance and SABA, and then Symbicort reliever. And you can see that now the Symbicort reliever is much better than the low-dose inhaled steroids and SABA, and that's because in the real world, patients are not using their Symbicort, their budesonide inhaler. And people thought because you were achieving control with a lower dose of inhaled steroids, you may not be treating the underlying inflammation adequately because they're on a much lower dose of inhaled steroid overall. So they used exhaled nitric oxide, FeNO, to measure inflammation. And what they found is that the SABA reliever didn't reduce FeNO, which we already knew. There was a similar reduction with the Symbicort reliever as when they were taking inhaled steroids. So it does seem to control inflammation, which is why it reduces exacerbations and improves control. So this is a follow-up study in general practice in New Zealand, where they compared these 2 treatments, so Symbicort reliever versus inhaled steroid and SABA reliever. And again, you can see that it reduces exacerbations. So if you put all these studies together in a meta-analysis, what you can see is that the patients on Symbicort reliever have a 55% reduction in severe exacerbations versus SABA reliever, and a 37% reduction in hospital admission compared with regular inhaled steroids. So this is the treatment of choice for the majority of asthma. And that includes not only mild asthma, but more severe asthma. So in this study, you can see they've used a different combination, which is combining budesonide with salbutamol instead of formoterol. And what you can see is that this combination is better than salbutamol alone. But I should say that salbutamol is not as good as formoterol as a reliever because formoterol lasts longer. It's the only LABA that can be taken as a rescue treatment. It's impossible to use any other LABA, including salmeterol, vilanterol, indicaterol. None of those can be used as a reliever because they have cumulative side effects, whereas formoterol is quite unique as a beta agonist in not having cumulative side effects. And we were already using maintenance and reliever therapy for people with moderate to severe asthma. And this is where patients are using ICS-LABA combination as the maintenance treatment, and then they use the same inhaler as the reliever. So they're using just a single inhaler, which makes the management of asthma much simpler for the patient and the doctor. And what you can see is that in all of these studies that are shown on this slide, the MART approach is more effective in reducing exacerbations and also in improving asthma control. So this has led to a change in the recommendations from GINA. So the preferred management of asthma patients now is that instead of a SABA reliever, they should every single patient with asthma should be switched to an anti-inflammatory reliever that contains ICS and formoterol. And this goes across steps 1 to 5. It's an important change because this will markedly improve the control of asthma in the world and should markedly reduce asthma deaths in the future. There is an alternative approach which is less effective, and that's using ICS-SABA or SABA alone, but it's not as effective in all the comparative studies. So anti-inflammatory relievers are now the treatment of choice for every single patient with asthma in the world. And we need to have a rapidly acting beta agonist combined with the steroid because patients are taking the inhaler for relief of symptoms. But the increase in symptoms is due to an increase in eosinophilic inflammation. So we showed that as people get worse, eosinophilic inflammation increases. And what you need is an increased dose of steroid to suppress the inflammation which is causing the symptoms. So anti-inflammatory relievers include inhaled steroid and formoterol, such as Symbicort, but there are other combinations. ICS-SABA is less effective, but may be cheaper in some countries. And for some patients with severe asthma, you may also add a long-acting muscarinic antagonist, although I must say, in our experience, LAMAs are not very effective in severe asthma. They are a treatment for COPD, not asthma. But what we know is that anti-inflammatory relievers are more effective at all severities of asthma. It treats the increased inflammation that's driving the increase in symptoms and addresses the issue of poor adherence, because we know that patients use relievers as soon as they have symptoms, whereas they never increase the inhaled. Okay, I use, now I'm going back to this one. Yeah. And the other very important thing is that this is cost effective because it reduces exacerbations and the use of healthcare facilities. So you actually save a lot of money by switching patients to this anti-inflammatory reliever approach, even though the anti-inflammatory reliever costs more than a generic SABA. So overall, it's the cheapest and by far the most effective way to manage asthma in the real world. But there are some patients that are not well controlled, even despite the fact they're using anti-inflammatory reliever or complying with inhaled steroids. And so we need some additional treatment for these patients. So these are patients with GOLD 4 and 5. So this is a minority of asthmatic patients. Only about 3% of patients with asthma have severe disease, although if you go to the ERS and the ATS, you would think every patient with asthma has severe disease. It's a very small minority of patients that are the ones that specialists see. In the UK, 95% of patients with asthma never once see a specialist. They're entirely managed in general practice. We only see about 5% of all the asthma patients in hospital clinics. So for these patients, they clearly need something else on top of their ICS LABA. And people looked at anticholinergics as an additional treatment because they work well as a bronchodilator in COPD. And you can see that in these people with severe asthma that are already taking maximum ICS LABA, that you do get improvement in lung function if you add the LAMA tiotropium once a day. So this is a clinically significant improvement in FEV1, and you also see a small further reduction in exacerbations. It's only about 15% difference. But the important thing is that adding a LAMA doesn't improve symptoms or quality of life because the bronchodilation is not sufficient to make the patient feel better. So we don't use LAMAs very much in our severe asthma patients, but the ones who respond the best to additional LAMA are elderly people with more fixed obstruction. In other words, these are people with asthma that also have COPD. It works better in non-eosinophilic asthma, non-T2. It works in people with asthma, what's called asthma COPD overlap, and we might discuss that in the discussion because there's a lot of controversy about it. I don't believe in asthma COPD overlap. I believe that people have asthma and COPD at the same time. They have two diseases, both of which need to be treated with different treatments. So because we're uncertain about which patients can benefit, we usually do a 4-week trial of adding tiotropium to see if there's any improvement in symptoms. And if this is the case, it's most convenient to give a fixed triple inhaler, although it's probably better to actually continue the reliever. We don't know if triple inhalers could be used as relievers, but probably they could. No trial has been done on that. So triple inhalers are strongly promoted by pharmaceutical companies, and actually the thing we feared has come about. So in the UK, GPs give triple inhalers to everyone that's breathless. They don't even measure their lung function because they've been told by a certain drug company that shall be nameless that they don't need to bother whether it's asthma or COPD because they're the same disease, so just give them a triple inhaler and they'll be fine. So this is a very bad thing because most asthmatics don't need a LAMA, and most people with COPD don't need a steroid. So it's the wrong approach for the majority of people. But there are indications for triple inhalers, and as you know, there's a big choice now. You have at least 4 triple inhalers available. Some are given once a day and some are given twice a day. And this is a study that compared triple inhalers against ICS-LABA in poorly controlled asthmatics. And as in the previous study I showed, there was an increase in FEV1 of about 100 mils, which is marginal in terms of symptom improvement. But there was no reduction of exacerbations, and what's more important, no improvement in the quality of life. And you can see the data here. So I would say that the use of triple inhalers should be very restricted in asthma because the LAMA is largely unnecessary. So severe asthma, as I mentioned, is the minority of patients, around 5%, but actual studies have shown 3% is a more accurate figure. But these 3% are difficult. I mean, it's a terrible disease for these patients. So they are often losing time off work, they get admitted to hospital, they may die from asthma. And this accounts for over half of the healthcare spending in asthma from this tiny minority of patients. And what is now recognized is that there are several phenotypes of severe asthma that you can distinguish by looking at the predominant inflammatory cells in the sputum. So about half of these patients have eosinophilic pattern of inflammation, which is known as type 2 immune response, or T2 asthma, and the remainder have non-T2, but non-T2 is very poorly defined because it's just defined as not having eosinophils. And actually, I think a lot of these are eosinophils that are suppressed by the steroid they're taking, so they probably would be T2. So my belief is that almost every asthmatic is due to eosinophilic inflammation. But some of these have a neutrophilic pattern of inflammation. Some may be COPD, and some have no inflammatory cells. So an important advance in the treatment of these patients has been anti-eosinophil biological therapies. So these biological therapies are very expensive compared with inhaled therapies and need to be carefully selected. The patients need to be carefully selected. And so in the UK, I don't know what your position in Argentina is, but we only allow biologics to be prescribed by specialists. So the GP is not able to initiate biologic therapy, because otherwise they would just give it to everyone that wasn't controlled because they're not using their inhalers properly. So these are very expensive treatments. They cost around $30,000 to $40,000 a year, which is a lot of money compared with inhaled treatments. So anti-IgE was the first biologic introduced over 20 years ago, and I've always found this a very disappointing treatment. You can't predict which people respond, but some people respond really well. I mean, they obviously have to have allergic asthma with increased IgE, but measuring IgE is not a predictor of response, and even non-atopic asthmatics with zero IgE could respond. So the only way you can see if it's working is to give a trial of therapy. But then we have much more effective biologics which target the T2 cytokines, IL-5 and IL-4, and then more recently one that targets both. So IL-5 is a very good target for treating eosinophilic inflammation because it's absolutely essential for the formation of eosinophils. So it's produced mainly by Th2 cells, which are the predominant immune cell of asthma, and also from the type 2 innate lymphoid cell, which is like a Th2 cell, but is an important cell for non-allergic asthma, and it produces the same kind of inflammation. But it can also be produced from other cells, and the main function of IL-5 is to differentiate eosinophils when they're formed in the bone marrow, but it also primes and activates eosinophils in the airway and prolongs their survival in the airway. So it's an extremely good target, which can be blocked either by mepolizumab, which is an antibody against IL-5, and we did the first study ever in humans on mepolizumab, showing that it markedly reduced blood eosinophil counts in people with asthma. You also have another drug, rosalizumab, which is not as good because it has to be given by intravenous injection. And then you have another drug, benralizumab, which blocks the unique anti-IL-5 receptor. So this is a study that looked at people with severe T2 asthma, so GINA 4 and 5, who were still symptomatic despite inhaled therapy, and they had increased sputum eosinophils despite taking inhaled steroids. So they're relatively steroid resistant. And you can see that there was a marked reduction in exacerbations. These patients are characterized by frequent exacerbations and hospital admission. So this is a very important reduction for these patients. But there was no improvement in lung function or symptoms. So this is not a replacement for inhaled steroids because it doesn't control asthma. It stops them having frequent exacerbations. Benralizumab targets the receptor and is a more effective antibody because it's cytotoxic. So when it binds to the IL-5 receptor on eosinophils, it actually leads to the death of eosinophils. So it clears eosinophils from the airways rapidly. And the other advantage it has, apart from its rapid onset of effect, is that it can be given every 8 weeks, whereas mepolizumab and rosalizumab should be given every 4 weeks. So that's something many patients prefer. But the clinical outcomes are very similar between mepolizumab and benralizumab. You get around a 50% reduction of exacerbations in people with increased blood eosinophils, but little reduction in symptoms. But the other important effect of these anti-IL-5 treatments is that you can reduce the maintenance oral steroids in the patients on GINA 5 group, because maintenance oral steroids are very bad for long-term symptoms. And many patients can completely come off oral steroid maintenance treatment. So it's dramatically improved the lives of many patients with severe eosinophilic asthma. The next drug to come along was dupilumab, which works by blocking the IL-4 receptor alpha, which is the common receptor for IL-4 and IL-13, which are other T2 cytokines that are increased in asthma. The problem of dupilumab is that it has to be given every 2 weeks by injection. But the good thing about dupilumab is that it's more effective than anti-IL-5. And there is a very good specific biomarker for dupilumab, which is measuring FeNO, which is a very simple test. So here you can see that dupilumab in people with severe asthma that is not controlled on inhaled therapy have a marked reduction of exacerbations. So it's more effective than anti-IL-5 in reducing exacerbations. But unlike anti-IL-5, it actually improves lung function. So it's a better treatment in terms of asthma. But the other advantage of this drug is that it's also effective in atopic dermatitis, which is the disease it was first developed to treat, but also chronic rhinosinusitis with nasal polyps. So it's not only treating asthma, but it's also treating allergic comorbidities that are extremely common in severe T2 asthma. So it seems to me that this is a very useful treatment for these patients. And now we have a new treatment that's only recently been approved, which is anti-TSLP. And TSLP is what we describe as an upstream cytokine. It's produced by epithelial cells in the airway, and it's very important for regulating T2 immunity because it instructs the dendritic cells under the epithelium to attract Th2 and ILC2 cells, which then release IL-5 and IL-4 and IL-13. So when we have a patient with increased blood eosinophils, we choose an anti-IL-5, usually benralizumab. When we have a patient with increased FeNO, we would prefer to use dupilumab. But now, with TSLP, we could treat both types of patient with the same molecule. So it's the opposite of precision medicine. So this is a study in severe asthma patients that were studied over a year, and what they can show is reduced exacerbations similar to the effect of dupilumab, and also an increase in FEV1 and quality of life. You see a reduction of blood eosinophils as you do with anti-IL-5, but you also see a reduction of FeNO as with dupilumab. So this seems to be an even better treatment to use for the future. And the response seems to be less dependent on blood eosinophils than with anti-IL-5. And this is a phase 3 study which looked at a larger number of patients and confirmed the results from the phase 2 studies with a reduction of exacerbations of over 50%, improvement of lung function and quality of life, maintained over 1 year of treatment in this study. So with blood eosinophils less than 300, which is what we call the non-T2 patients, there was also a reduction of exacerbations. I'm sorry about the typo. I think that should be 41%. So a 41% reduction is pretty good for these non-T2 severe asthma who didn't have any treatment that was working before. And more recently, it's been shown that with bronchial biopsies after tezepelumab, you see a reduction in airway eosinophils, which is what you expect, reduction in airway hyperresponsiveness, although in this study there was no steroid sparing. So in conclusion, asthma is poorly controlled in the real world, and that's because people are not using maintenance inhaled steroids, even when they're in combination inhalers, and they over-rely on SABA inhalers. So anti-inflammatory relievers are now indicated for every patient diagnosed with asthma, and ICS formoterol inhalers should now replace SABAs as relievers. So we have to get rid of SABA inhalers, because they're cheap but potentially lethal. Severe T2 asthma can now be targeted specifically with anti-T2 cytokine drugs, which in the future may eliminate the need for oral steroids that are causing a lot of side effects when used as maintenance treatments. And there are new biologics for T2 asthma that are now in development. So even last week, a new anti-IL-5 was approved, which only has to be given every 6 months. It's called depemokimab. So that may be more convenient for some patients that don't like injections, or maybe children. For severe non-T2 asthma, you can try a LAMA and then a triple inhaler, but we don't think this is a very effective treatment unless the patients also have COPD. But there are new small molecules and biologics in development for neutrophilic non-T2 asthma that have not yet shown any clinical benefit because the trials are currently ongoing. So the way we treat asthma has dramatically changed. And if you discover a new drug which is a cure for a disease, it takes 20 years before GPs start to use it. There's such a big lag. So what we need to do as specialists is promote the new way of treating asthma, which is not only more effective in controlling asthma, it has less adverse effects, which is less inhaled steroids, but it's the cheapest way of controlling asthma. So I think this is the most important message. And then you have the small group of people that you see in your clinics where you have these very effective new biologics, but have to be very carefully used because of the high expense. So thank you very much for your attention.
Thank you very much, Peter. Now I would like to know if you have any question. Perhaps who is going the first? Okay, go ahead, please.
Congrats, doctor. Yesterday you talked about immunosenescence and these new xenocytic strategies. It would be a good idea to combine these xenocytic strategies with anti-alarmins to promote a healthy epithelium over the time?
Well, there's very little evidence for senescence in asthma. There's very little evidence for senescence in asthma epithelium, except in the patients with severe non-T2 asthma, which I think is COPD. So I don't think it's an approach for these people, but as I discussed in the talk yesterday, it's an important potential treatment for COPD in the future.
Do you think in poor countries that the combination of corticosteroid with SABA could be a partial start, a begin of the change to kill the SABA alone?
Yes, I do. I mean, it's not as good as formoterol as the reliever because formoterol lasts longer. But it works. I showed the study of PAPI where they looked at salbutamol with budesonide. But I don't see why budesonide and formoterol shouldn't be the same price because, I mean, they can make formoterol easily. So it's just a question of the marketing price. I mean, what will happen, of course, is that formoterol, ICS, anti-inflammatory relievers are going to be generic. I mean, they already are, because you can get budesonide formoterol, and there are in some countries, you can get salbutamol ICS combinations already on the market. So I think these can be used, but the formoterol one is better, but It's certainly, as long as you have an inhaled steroid every time you take a reliever, that's the key thing, is getting people to use inhaled steroids when they need an increased dose. So it's less important what the beta agonist is than the idea of combining with a steroid. And it doesn't matter what the steroid is. So similar studies, I didn't have time to show them, have been done with formoterol and BDP. And those studies show exactly the same results as with the Symbicort reliever. So you could do it with different combinations. And I guess you in a poor country, you choose the cheapest one.
Thank you. Okay, go ahead.
I want to know your opinion about the use of azithromycin or low doses of theophylline in severe patients with an asthma.
Well, theophylline, as you know, was used as a bronchodilator in quite high doses when it would commonly have side effects. So it was quite complicated to use because the pharmacokinetics of theophylline were affected by a lot of factors like age and whether people were taking other drugs. So theophylline was always quite difficult to use. But then people discovered that a low dose of theophylline had anti-inflammatory effects at doses that were lower than the bronchodilator effect. And we showed that adding a low dose of theophylline would actually improve asthma control when you added it to ICS-LABA. So it was quite common to use low-dose theophylline. We still use it in our severe patients, although I think in GINA they don't recommend it. But it's a good treatment combined with ICS-LABA, and it's quite a cheap therapy. So it's very commonly used in China. So I think it should be considered. And we found that some patients respond really well to low-dose theophylline. We did one study where we took people in our clinic who were on theophylline, and we substituted theophylline for a placebo and kept some on theophylline. And all the ones that were taken off low-dose theophylline deteriorated. So I think it is a useful treatment still. And you asked about macrolide. Yeah, well, this is quite controversial. I mean, there are studies that have shown that in non-T2 severe asthma, that if you add azithromycin as a like three doses a week regime, that you do get reduced exacerbation. And the thinking is that it may target neutrophilic inflammation rather than through any antibiotic effect. So I think it's something to consider in the non-T2 patient that's still not controlled, even if you try a LAMA. So it would be the sort of fourth choice of drug for those people. And some of them seem to do quite well. But of course, taking regular macrolides may have side effects. So in elderly people, there's an increased risk of deafness. There's a risk of cardiac arrhythmias. And the biggest problem is that you may get antibacterial resistance, because we know that some of these non-T2 asthma patients have colonization with Haemophilus. And that's because I think they have COPD myself. But other people argue against that, but I think they're wrong. So I think macrolides have quite a small role, but they have a greater role probably in COPD, which I come to in the next talk.
Okay. Yes?
Some years ago, I was involved with the national guideline for mild asthma, and we recommended starting with the ICS and LABA for relievers. And there were some people in the panel that were very vocal with the concerns about leaving inflammation untreated They said, well, actually, when you use as needed therapy or an ISTS, there is still evidence that the vaccination will still go on and on. We said that we have no real evidence of a harmful impact of that, but what are your feelings on the matter?
I think that's a very good point, and that was a big concern of people, because you're using 75% less inhaled steroid compared with a dose that controls them. So you would think that it wouldn't be as effective against inflammation. But I think the point is that it's targeting when they get symptoms, and we know that symptoms reflect inflammation. So that if you actually measure FeNO, which I showed in that New Zealand study, they found that it was as effective as inhaled steroid regularly, because it's really about the timing rather than the dose. So you're timing the increase of inflammation with the steroid, and it may not be required between symptoms because you have so little inflammation. But I guess we have to look at longer term studies, because the effect of not treating eosinophilic inflammation may be irreversible narrowing of the airway. And we know in asthma this would take many decades to occur, so it could be that we're under-treating, but I doubt it. But anyway, it's better than what we do now, because they just don't use inhaled steroids at all.
I have a question con respect to clinical practice. Taking into account what you have explained about LAMA in T2 severe asthma, do you always add LAMA before indicating biologic agents, or you consider add biologic agents just with inhaled steroids in high doses and LAMA? And if is there any requirement of health or the authorities of this?
I don't understand the question.
Now, taking into account what you have explained about LAMA in T2 severe asthma, do you always add LAMA before indicating biologic agents, or you consider add biologic just with high doses of steroid inhalers plus LAMA? And is there any requirement of the authorities of health in your country?
No, I don't. As I said, I don't think LAMA are very good in severe asthma unless they have fixed obstruction, which means COPD. So to qualify for a biologic in the UK, they have to be on maximal inhaled therapy, and they have to be shown to be using their inhalers correctly and still have symptoms after that. So we know that 20% of people with asthma have symptoms despite being prescribed maximum inhaled therapy. But only about a quarter of those patients actually have severe asthma. Mainly they're not using their inhalers, or they don't use the inhaler properly. So to qualify for a biologic, they have to be shown not to be controlled on the maximum dose, which has been shown to be used by the patient, and you can measure things to monitor adherence. And then they also need to be using the inhaler device correctly, because it's astonishing how many patients don't use their inhaler devices correctly because they've never been taught. But in the UK, we have a very good system for managing asthma in general practice, where we have specialist asthma nurses who actually work in the general practice, and they know much more about asthma than the GP, because the GP is seeing every disease, so they don't know so much about asthma. But these nurses know everything, and they know how to teach patients to use inhalers and how to monitor asthma, and so they basically run the asthma patients in the UK. And it's a very efficient system, which should be adopted by other countries. I think the Netherlands now uses the same system, but it's a highly cost-effective approach to managing asthma in the population. So that's what we recommend.
A question about definitions and nomenclature. You talk about mild asthma, severe asthma, moderate asthma. Why that terminology is not applied in GINA? Because steps in GINA are confusing. And somehow we are all used to a better nomenclature, or simpler, I think.
It's in GINA because steps 1 and 2 are mild, step 3 is moderate, and 4 and 5 are severe. Well, 5 is very severe. But I think it would be probably easier to use simple words than steps. I mean, I think for specialists it doesn't matter, but probably for GPs, because I don't see why GPs should learn every single guideline for every disease they teach. So we need to make things much simpler for GPs, but not too simple, because now, as I mentioned, the GPs are just use triple inhaler for every patient that comes into their clinic, which is a shocking overuse of treatment. But we have to educate GPs not to do that. And the problem is that there are some academics who go around the world giving talks saying that asthma and COPD are the same disease. This is totally wrong. They're completely different diseases in almost every way. The only things they have in common is that they're both common and they both have airway obstruction that leads to the same symptoms, but they're completely different diseases that should be treated differently. And it's terrible now that in the UK, the GPs just give triple inhaler to anyone that's breathless. They don't even measure the lung function. People say, oh, I get breathless walking up the hill. They say, oh, take this inhaler, you'll be fine. They don't do any tests, they do nothing. And this is promoted by a certain pharmaceutical company. It's totally unethical.
Okay.
But it's our responsibility as specialists to educate GPs to use the treatments properly. I mean, I think it's unethical to give high-dose inhaled steroids to people with COPD because they have side effects. And it's unethical to give anticholinergics to people with asthma because they don't need it. So it's a wasted drug, and it can have some side effects, although pretty well tolerated.
A question about here, mild asthma and how if many patients with mild asthma, with well-controlled asthma, despite being well-controlled with no symptoms, no exacerbations, will develop during the time remodulation and fix obstruction. Is there any way to predict that, apart of non-smoking and pollution? Because some patients in the Navigator study showed that some patients do progress despite well-controlled asthma.
They do, and I mean, some of them progress because of smoking, or maybe they're exposed to air pollution, which we now recognize as a significant risk factor for COPD. The ones with non-T2 asthma, which I think have COPD, may also be developing because they have a persistent neutrophilic inflammation. Although you're giving steroids, it's not reducing that. So they can develop fibrosis of the airway. And then there may be some that are very susceptible to developing airway fibrosis. But the fibrosis that develops in people with asthma is different from the fibrosis of COPD. So the characteristic of asthmatic airway and fibrosis is that it's collagen fibers underneath the epithelial layer, so-called subepithelial fibrosis. And this is very poorly related to airway function. And even when they first diagnose asthma in children, they find that they have this subepithelial fibrosis. So it happens very early in asthma, and it may not have much significance. Whereas the fibrosis of COPD is surrounding the airway. It's called peribronchial fibrosis, and it progressively closes the airway because the airway is becoming progressively narrower as the fibrosis advances. And so that's a different type of obstruction, which is more progressive. So I think when asthmatics have progression, it's likely that they have this peribronchial fibrosis. But we don't know because there are no studies looking at the histology of those patients.
Yes?
Thank you for your presentation. I want to know your opinion, or maybe your vision about the next 10 or 15 years in the management of asthma.
Oh, this is a very difficult question.
Sorry.
Well, I mean, what we need is a cure for asthma. I mean, we need one drug that you give once that switches the disease off forever. And this is something that may be difficult because you may have a downside to a cure because it may make other diseases worse. So if you switch off T2 inflammation, it could be the case that T1 inflammation increases. And so it may be very difficult to achieve a cure. I think what we see now is a trend for these longer-acting biologics. So as I mentioned just now, the 6-monthly mepolizumab type anti-IL-5 has just been approved by the FDA. And so 2 injections a year is probably more convenient, especially for children. So I suppose longer-acting biologics, but they're still very expensive. So we have to think about whether there might be any more effective treatment. But it's difficult to think that you could have a more effective anti-inflammatory treatment than a steroid for asthma. I mean, no drug has ever been better than a steroid. But the people with severe asthma are not controlled by steroids by definition, and that's because they have steroid resistance. And several years ago, we spent a lot of time trying to understand the molecular mechanisms that stop people with asthma responding to steroids. And there are different mechanisms of steroid resistance. Some of them involve different signaling pathways like P38 MAP kinase, which you can block with P38 inhibitors. But the problem is they have terrible side effects, so people don't want to use them anymore. So no P38 inhibitor is used for any disease. So people are looking at other treatments like JAK inhibitors, which look quite promising for asthma because they inhibit all of the T2 cytokine pathways. So people are looking at JAK inhibitors by inhaler because they are quite having a lot of side effects if you give them by mouth. So there are some new drugs, but I find it very difficult to think we're going to get anything better than an anti-inflammatory reliever. I mean, I suppose, no, I really can't see anything better than that. But I think we may see improvements for the treatment of severe asthma, where we have less frequent drugs. And of course, but it's such a small population. I mean, 3%. They did a study in the UK looking at, if you look at typical asthma patients in general practice, where they are, they found that only 1% of patients in general practice with asthma fulfill the criteria for biological therapy. I mean, 1% is we shouldn't be so concerned about this tiny proportion of people, which is what the whole of the ERS and the AT, you never hear about mild asthma or even moderate asthma. You only hear about severe asthma because it's driven by the pharmaceutical industry. But if I was advocating for patients, I would be more concerned with finding better treatments for mild asthma, which is what 70% of people with asthma have. And before the Sigma trials that I talked about, there was not a single controlled clinical trial in mild asthma, which affects 70% of the patients, which is quite shocking. But there are probably 1,000 trials in eosinophilic severe asthma affecting 1% of the population. Quite ridiculous.
Hey. Thank you, Professor Barnes. I will change the question. Don't you think that we have good medications for asthma, and perhaps next years we have to work in the access and in the properly use of the pharmacs?
You mean of inhalers?
Yes.
Absolutely. I completely agree with that. Is that, I mean, the drugs we have now are pretty, so if you look at ICS formoterol, they're all going to be the same. The only difference is the inhaler device. So the inhaler device becomes the key discriminator for which are the best drugs. And the only inhaler that's useful is the one the patient uses properly. So some patients prefer MDI, and some patients prefer dry powder inhalers, which are the two main types, as you know. And what happens at the moment is that people are usually given a reliever as a metered dose inhaler, and the maintenance treatment is a dry powder inhaler, which is ridiculous because the techniques for using an MDI and a dry powder inhaler are completely different. And GPs don't know that. 95% of GPs don't think there's any difference between MDI and DPI. But they are completely different. And I think for the anti-inflammatory reliever, personally, I think an MDI is better because patients are used to the spray in the back of their mouth. And it's like Pavlovian conditioning because they equate the feeling of the cold spray with the fact their symptoms go away. So then they're using the inhaler to relieve something bad and it gets linked. But with a dry powder inhaler, there's not such a link. But I don't think it matters whether they use an MDI or a dry powder inhaler, as long as they use it correctly. And so, if a patient's using an MDI reliever and a dry powder maintenance, that's very confusing because they have to be used in a completely different way. But the patient is not told that because the doctor doesn't realize that's the case. So I think it should be a choice. There's a big move against MDI because of air pollution, but they're saying that the propellant is a greenhouse gas, but it's a tiny, tiny effect that can barely be measured and shouldn't be taken seriously. And actually, people have now calculated that the manufacture of dry powder inhalers is actually more damaging to the environment than the manufacture of MDIs. So overall, there's probably no difference for the environment.
Professor, I have two questions. First, if you believe in the new concept of remission, and the second, Probably I am confusing about the sentences that you told to us. When you talked about severe asthma with persistent airflow limitation, you said, okay, this is patient with COPD. This is real or I am confusing?
It's a point of view. I mean, it happens to be my point of view, but is not the point of view of other academics. It's not the view of certain pharmaceutical companies that have used this uncertainty to promote their products that are triple inhalers. So I think it's something that needs to be clarified. I actually wrote an editorial on this topic in the Journal of Allergy and Clinical Immunology just a couple of weeks ago, or maybe a month ago, which discusses this issue. And it's become a really important issue now because the first biologic, dupilumab, has now been approved for use in COPD. And if you look at the dupilumab studies, well, maybe we talk about that when I come to COPD, but my interpretation of the dupilumab studies is that they're treating the asthma that these COPD patients have. So they're not treating the COPD at all. And what is particularly pernicious is that now they find there's a small group of people with COPD that respond to dupilumab. They're people that have reversible airway disease, high blood eosinophils, and frequent exacerbations, which are all the features of asthma. And what happens is a drug gets approved for those people, and once the drug is approved, they give it to everyone with bad COPD because there's nothing else. So it's a Trojan horse to sell a drug that will not work in most people with COPD, but will cost $30,000 a year for not working. It will work on the rhinitis that they may have, but that's another disease. So I think this issue about asthma and COPD now has to be discussed in great detail, because otherwise patients are at risk of being given these treatments which are never going to work on them, because it doesn't work on COPD. It works on the asthma that they have. And it's quite misleading to say that this is the first biologic for COPD. It's the first biologic approved for COPD, but it's not treating COPD.
Okay. If no more question, okay.